And I introduce Pam, who's a consultant sonographer at Hull University. And Pam is going to talk about liver contrast enhanced ultrasound, the importance of the collaboration between the radiologist and the sonographer. Thanks very much, Pam.
Thank you for inviting me. There's been two really fascinating, interesting talks. But today I just want to concentrate on how do we set this service up, because I'm acutely aware that within the UK, contrast is used a lot and widely in echocardiography, but less so in radiology. And one of the questions I get asked very often is, how am I going to set the service up? So I was asked to talk about the importance of collaboration between consultant radiologist and sonographer. I'm just going to change the titles slightly and just saying contrast in the UK, delivering it as part of a multi-professional team, because it's not necessarily a sonographer radiologist relationship, but there are other members within that team that we need to consider. So the presentation, well, first of all, we're going to discuss why bother. Now, we've heard two really good presentations about the use of contrast, but I want to talk about why we're going to bother using contrast in a general, busy radiology department. I'm going to look at the 7 key ingredients that you need if you're going to take this forwards. I'm going to also look at role extension and skill mix. Who is the right person to do it, and how do we learn from each other? Considerations for some of the non-medical practitioners using SonoView in the UK, and it's a different world than it potentially is in Europe, in the fact that sonographers are clearly not medics and they will be using SonoView within delegated practice. And then we're going to look at some of the pathways. Now, throughout this presentation, I've got some examples of when we have used contrast within our practice here in Hull. This is a warning. I know the presentations today is supposed to be about liver, but it's not all liver today. And that's why a multi-professional team is required. As Paul's already alluded to, the licensing of SonoView makes it a little bit difficult for non-medics to use SonoView outside of its license here in the UK, but I'm going to show you examples of how we can and why we should. So just let's look at this first case. Okay, this is a case that we see regularly in ultrasound. It's an incidental finding of a solitary liver lesion. Paul's already talked about the next best practice, but if you don't have contrast, or you're thinking about contrast, what should we do? So here's a homogeneous or hyperechoic liver lesion. Well, the first thing I'm going to recommend, because obviously I've got my BMIS hat to promote as well, is that there are some guidelines for incidental findings. So BMIS generated these last year. So what do they say? So if we look at this, there's an incidental liver lesion. It's well defined. Now, the lesion we've just identified was 3 centimetres. So what should happen with that? Well, under 3 centimetres, we can report as hemangioma. But this is just over 3, so what should we do? Well, in the guidelines, we don't actually recommend contrast as an only tool, although clearly it's in the NICE guidance and EFSM guidance, but it does recommend that local practice, and this is some evidence that you can use if you haven't used contrast before, you're looking to set this up, to say, well, actually, further investigations are warranted and we might want to consider contrast, given the demand and the pressures on CT and MRI in post-COVID recovery. So here's this lesion again. This patient's come back for our contrast list. You can see that the lesion is not as well seen. We're in the longitudinal section. We give contrast. This is in the portal phase at 48 seconds. You can see this nodular peripheral infilling. And then as we move on, it's starting to fill in slowly. And this will confidently say this is a hemangioma. We don't need any further follow-up. The patient can be reassured. And Paul made the point about the fact the patient's in front of you, and that's really important. It's a really bonus for doing these types of scans for your own satisfaction, but also for that patient. So here's a second case. Okay, we see these regularly. We have 5 satellite sites here in Hull. This patient's been scanned in the community, and there's this in the kidney. Is it solid? Is it not? Now, looking at that, just with those views of on a fundamental, I'm slightly concerned. So what should we do about it? Again, I'm just going to highlight the incidental findings from BMIS. What do we do with solid focal lesions within the liver, within the kidney? Well, this is where it becomes a little bit more tricky. Barn-door angiomyolipomas, dependent on the size, clear cut. We know that angiomyolipomas usually homogeneous, usually echogenic. That wasn't. Is it totally solid? Well, I'm not quite sure. So we're a bit uncertain. So what do? We can ask for a second opinion from a radiologist or experienced sonographer and do some further follow-up imaging, and it's dependent on local policy. Now, our local policy with these equivocal and uncertain findings, if they don't look like a mass, then we come for contrast. And we can see this is the same kidney. This is well into the late phase, but this perfused cortex is the same all the way around. These are the pyramids, and I'm happy that actually this is a bizarre but sort of fetal lobulation with a bit of column of Bertin. This would on contrast imaging was a normal kidney. Patients reassured, and we're all happy. I don't know how many of you actually do EVAR follow-up. So this is an aortic, endovascular aortic resection. This is the stent within the aorta. This is longitudinal section. Now, I don't know if you can see the measurement. This is 8 centimeters AP. I don't particularly want that. It's not a great size, but the sac is actually stable. So this has been 8 centimeters, but what's going on in there? Contrast has got a really valuable role in following up EVAR repairs. Now, this patient, we can see the stent here. This is a non-perfused sac around it. See contrast within the stent, but if you just see here, just a blip of contrast coming in at the neck of the aneurysm where the EVAR was started. And in actual fact, what we're looking at here is a persistent type 1 endoleak, which can be easily diagnosed with contrast enhanced imaging. The patient doesn't need a CT angiography. They can be followed up easily with contrast. So I want to show you another case of a EVAR follow-up. So this is a patient with a slightly smaller sac. You can see this is a transverse image with flow within the stent just here, no flow within the sac, but we're actually very early in the contrast cycle. This is 14 seconds. So what happens as we leave it for a minute? So there's the stent, this is the aneurysm sac, and you can see all of these areas are actual contrast leaking into the aneurysm. And because of the time that this happened, we know that this is a type 2 endoleak, but in this patient, unfortunately, the sac size is increasing, so combination of contrast and the sac size increase, we are now able to direct this patient into appropriate imaging that can then potentially repair. This patient goes for angiography, and you can see there's some flow from the lumbar vessels, and they can be easily embolized. This is the follow-up contrast scan. Yes, there's a persistent leak, but it's no way as extensive as it had been pre angio and embolization. So contrast has a really good role in managing these patients without the need for any other imaging. So if contrast is so good, why are we not all doing it? Why do I keep getting asked, how do you set up a contrast service in the UK? Well, I think there are 7 key ingredients to make contrast happen, very much like a Christmas cake, because I know you're all busy thinking about that. So the first one is it's got to be a shared interest. When I started doing contrast back in 2004, I worked with a radiologist, a consultant radiologist, and a fellowship registrar. We'd not done contrast here in Hull before, and it was the 3 of us working together to try and decide how best to use it and on which patients should we use it on. So with that, we actually had a shared learning, and there were some really difficult times of when we started. The equipment was not to the same standard as it is now. We sometimes weren't sure what we were looking at, but we learned together. How did we learn together, and how did we implement it? Well, as a team, we identified the drivers that really could make contrast happen. So where is the peaks in demand? What can we take off other pressured areas that we could potentially improve patient throughput, reduce capacity, reduce demand in other areas? But also, what are the barriers? Well, the barriers, often people quote cost. That's one of the easier ones to actually justify. Some of the barriers are about the uncertainty of what we're looking at, the confidence of what you're diagnosing, how it's interpreted at MDTs. Ultrasounds are not easy to look at if you're not skilled in this area. You will clearly have to have appropriate equipment, but that's a lot easier nowadays. Most general radiology ultrasound machines will have contrast as an optional extra. Funding and wider support. Everything costs money, but if you can demonstrate that actually we're going to add value and benefit to the patient care, then that's something that's relatively easy to justify. What you do need is that wider support from not only your radiologist colleagues, but the medics around that are referring into your service that are suddenly going to start getting reports back that they might not be aware of or understanding. So it's that communication that we are going to change some of these pathways. There has to be supporting documentation. Your practice has to be safe, regardless of whether you're a sonographer, radiologist, or whoever is doing contrast. You need to make sure that you are following local and national guidelines. And then once you've got all that together, well, audit, prove it works. It's like tasting a cake. You wouldn't put all those ingredients together and then not check that things were right. So if you are going to do contrast, follow them up. So let's look at all of these ingredients in turn. So shared interest. Well, for one thing, if you can say to somebody and you can evidence that what you're doing adds value to the scan for that patient, well, is an interest. That's what we're in this business for. We want to give the best test to our patients. We should give them the right test at the right time. And if ultrasound can extend what we do to improve their care, then surely that's something to be proud of. I have a team of sonographers that are working with me now, developing contrast skills, and you can clearly see that it's increased their job satisfaction, increases their motivation, and overall we are taking pressure off other services. Definitely we are not requesting repeat multiple CTs on these patients. So it is a shared interest for all of us within radiology to make this happen. The other thing we need to think about is this shared learning. It's not common for radiologists and sonographers to learn a new skill together. We've come from different backgrounds, we've come through different training routes. But what we are starting to see, and you'll see in the next 2 years, are imaging academies that are coming through to develop shared learning of undergraduates, postgraduates, and registrars. If we can start learning together, we're going to know what tests benefit which patients. And I do believe that as you start to learn with other people, you will not feel so isolated. If you start a service on your own, be that a radiologist or a sonographer, if you start to feel isolated, then you're going to be demotivated and difficult to discuss those difficult cases and patients and try and understand and learn together. But for shared learning, as a team, you need to have excellent communication. You need to embrace learning together, put aside your professional boundaries and really just promote supporting each other. And peer learning and collaboration has been proven to enhance development. So one take-home message from this, both of you get involved, whoever's interested, learn together and take it forwards. So I'm going to give you a couple of cases where shared learning still continues. Now, as I say, we've been doing contrast in Hull since 2004, so I'd like to think that I've seen quite a lot of instances. But this is a report that was sent through to me, and it talks about a CT scan with a lesion associated with the 9th rib. Not sure what it is, recommend a contrast enhanced ultrasound in the first instance. If it's from the chest wall and there's internal vascularity, then MRI might be the next appropriate investigation. But come to ultrasound first, let's see what it is. Excuse me. So you can see the CT, there's a lesion just here on the chest wall. And we're really fortunate in Hull as well. We have fusion guided imaging, which I'm going to talk to you about with a few of these cases as we go along. But we're able to fuse the CT and absolutely correlate with the ultrasound where this lesion is. Now, on CT, you lose that border, but you can clearly see on ultrasound the capsule of the liver is being indented by whatever this lesion is. So we're already happy that this is not a liver lesion, but what the heck is it? So we give some contrast. This lesion has now got some internal perfusion in this sort of pattern. It looks a little bit complex on fundamental imaging. Now, I'm not certain, so let's go back to basics. Let's actually look at what this is. Put a high frequency probe on. You can see efferent and afferent vessels. You can see this heterogeneous kind of well circumscribed mass, but with some posterior enhancement. These features are very typical of a peripheral nerve sheath tumour. Now, I've never done a contrast scan on a peripheral nerve sheath tumour, but just the fundamental appearances of ultrasound, the contrast has demonstrated it's got flow in it, but in actual fact, it's the ultrasound that's helped here. But We're still not quite sure, so we've referred to plastics and let them decide what to do with it. So this is another case that's a bit of a conundrum where we're still learning together. This is a patient, a GP patient that's come through for, I think it was a renal tract scan, incidental finding of a lesion in the gallbladder wall. We can see here, well circumscribed. Again, the radiologist has been asked for his opinion, reviewed the imaging and suggested contrast enhanced imaging. Now, I'm starting to think that this is an easy option. Let's go for contrast because hopefully somebody else can tell us what it is. And I have to say, well, why would we do this? We're not usually doing contrast of gallbladder walls, but there's some paper that came out in 2021 that is identified that the combination of a conventional ultrasound and contrast ultrasound can differentiate between cholesterol and adenomatous polyps, and that will make a difference to how these patients are managed. So there's good evidence coming out that contrast of gallbladder wall polyps is a useful tool. So we've given contrast. You can see flow here within the lesion, and again this well circumscribed area within the gallbladder fundus, and just here. But this is shared learning that we're talking about. So I've gone to discuss the case with a consultant radiologist saying, well, what do you think this is? Because it doesn't look typical for a gallbladder polyp. I haven't done many contrast scans on gallbladder polyps, so what do we do? Well, it's probably benign. Gallbladder cancer is incredibly rare in the absence of gallstones. So what we're actually going to do is reassurance imaging in 6 months and hope that in that time some magical answer, particularly comes off my fellow panelists this evening, will come out and tell me what this possibly could be. So I've shared these 2 cases with you because in actual fact, we learn all the time, we continue to learn, but that doesn't put us off. That shouldn't be a barrier to us actually embracing contrast scanning. There are many drivers that we should be looking at. Now, technology has got so much easier. There is a lot on the market that makes contrast readily accessible. There are now national optimum pathways for imaging. The rapid diagnostic pathway changes. We are going to see an increase in incidental findings. The more patients that are scanned for non-specific symptoms or who go in for CT colonoscopy, we will find these little things that we don't know what they are. Is CT imaging the right answer? As Paul's demonstrated already, no. There's clearly an increase in demand, and if we can reduce the amount of rescans or actually do the right test first time, we're going to help those patients through the journey a lot quicker. But clearly there are barriers. We need time in anyone's job plan to make this happen, particularly in the early stages of being able to train and have time together to learn, understand the technique, but also follow up the patients. We also need time to develop confidence because there will always be times, as I've just shown you there with cases that you have absolutely no idea what they are, complex cases, the cannulation doesn't go quite right, the patient doesn't feel very well. We need to build your confidence that you can deal with those things. Funding, as I mentioned, is always a barrier to everything, but again, I think the case can be made. One thing we do need to be aware of is there will always be interprofessional protectionism. Is this the job for a radiologist? Is it a job for a sonographer? My answer is it's a job for somebody who works in ultrasound, who can scan, who wants to do the best for the patient. So when we talk about time in job plans, we need to consider that that time is money well spent. You spend to save. If you can increase somebody's confidence and skills in contrast scanning, you will negate the need for onward CT and MR referrals. Is this actually something that ST4s and 5s can be utilised to help support sonographers with? Does that then motivate those registrars coming through? Promote ultrasound as a really good, modern, up-to-date imaging modality. It's going to promote role extension and skill mix. Happy staff are more likely to stay with you. So let's look at the benefits of introducing new techniques to actually increase the range of skills that somebody has. And that shared learning and confidence grows, the service suddenly becomes achievable and definitely something that should be considered. But sometimes contrast isn't the right thing. And we just need to be aware that if you are starting out in a service, do not be put off. So this is a patient with known cirrhosis. There's a small lesion, or 2 centimetre lesion in segment 8 on MRI. So we're going to follow those up. Patient then also has a CT. The subtle lesion remains as before, 2.3 centimetres. It's seen on MR and CT. So actually, well, why don't we look at contrast enhanced scanning? Let's put this lesion through this service, avoid cross-sectional imaging. However, sometimes we just can't see things, and I'm going to show you this case. Do not let this put you off, but just be aware it can happen. So here it is, the lesion that you can see quite easily on MRI. I can't see it so well on CT. I'm sure some experts might be able to. I think it possibly is there, but really difficult, in my opinion, to see. Even more difficult on ultrasound. So again, we're using fusion guided imaging. In this instance, we've tried to fuse with the CT, which is difficult if you can't see the lesion very well on CT. But as you can see here, we've got rib shadow, we've got a coarse liver texture, access is difficult. So we can scan through this liver. We've given contrast. This is early stage, typical appearances of a cirrhotic liver with arterial enhancement. We've scanned through with the late phase, looking for any hypoechoic or hypoperfused lesions. We haven't seen anything. And I think we just sometimes have to say that perhaps, yes, contrast ultrasound can be a tool, can be a really useful tool, but just be aware that sometimes it won't act in your favour. But that's not a barrier to not do it. So the fourth key ingredients to making this service happen is equipment. Nowadays, all contrast equipment will come with a split screen. When we first started contrast enhanced imaging, you used to turn into a contrast mode, and you would not have any guide fundamental image. You had to hope and pray that you hadn't moved away from the small area. Now it's much easier for you. There's this split screen which allows you to display real-time imaging in both fundamental and low MI values of contrast scanning. You need to make sure that it's set up properly, and that's what your application specialists are there to do. BRCA specialists and application machine specialists will help you set this machine up and get it right. If not, ask some of the experts, what kind of settings have you got? How do you make it work? You also need to think about, do you really need contrast enhanced ultrasound? Obviously, this presentation tonight is trying to sell it to you, but yes, I think you do. You do need to think about this side-by-side functionality, but also consider things like the superb microvascular imaging that is within Canon machines. Those low velocity colour flow mapping can really help you decide that, yes, that's the technology that you do know, and it can be an adjunct to contrast. If I was to buy a machine, one of the things I would really urge you to do nowadays is to include fusion. A vast majority of our referrals come from incidental findings on CT and MR. Without fusion, the confidence of knowing I'm in the right area is definitely limited. So I would urge you, if you've got some free cash, really consider adding fusion into the mix. And how many machines do you want contrast on? And the reason I ask that is, how are you going to set your service up? Are you going to be doing contrast on every patient you find an incidental finding at that time? Or are you going to do, as we do here in Hull, where we have a dedicated contrast list, and it's effectively a problem-solving list? Patients with incidental findings on any of the other imaging modalities are booked onto that contrast list. We have 2 a week. They come in, they get scanned, it's focused, it's problem-solving, it's got an identified function, but it's also absolutely ideal for training and motivating other staff. They can join me, see what's happening, and start to learn skills. However, that's countered with the fact that the patient has to come back. So it will be what works best for your service, but for us, dedicated contrast lists really work. So this, I want to give you an example of some fusion imaging and how useful that is. And these patients have come onto a contrast list, but sometimes it's just not needed. This is a patient that presented with suspected pyelonephritis. They had a CT, and there's this unusual area within the right kidney. They've arrived for an ultrasound scan to try and clarify what that is, and they've got this hypoechoic mass, really not added very much in value. It looks solid, but what could it be? The patient's presenting with raised white cell count, likely to be an infection. So we can then offer a rescan. Let's see how this progresses. Does it resolve? Now, this is a superb microvascular imaging, so SMI imaging on Canon, and you can see the perfusion in a nice pattern throughout the cortex. That lesion has resolved. I don't think this patient really needs anything further. This is another patient that presents, has a CT, then has to have an ultrasound scan because they've got this bizarre lesion within the kidney. And you can see this is actually got calcified walls, some internal architecture we're not certain of. Now, this really lends itself to some contrast enhanced imaging. Contrast has shown normal perfusion throughout the renal cortex, but this really complex mass that we were uncertain of actually doesn't perfuse at all. This is a cystic structure. Yeah, there's a calcified rim, but in actual fact, there's nothing in there to suggest there's any internal perfusion or that this is a solid mass. In fact, this patient had TB, and this is a previous TB abscess of the kidney. So we need to think about funding. There are costs at the setup that you do need to consider. Cost per vial of contrast has to be taken into account. But equally, if you're on a tariff payment for your ultrasound services, then that will be recouped through those mechanisms. You do need specialised software on your machine, and you do need to think about cannulation, not just cannulation equipment. Obviously, you need your cannulas and all the peripheral accessories that you need, but you also need to understand who's going to cannulate. Now, in a radiology department, there's likely to be a CT department that are cannulating all day long. Can you tap into that service? Because really, try to avoid cannulating in the room. It delays the list. If the patients can come to you already cannulated, that is really helpful. But if not, then that's something that needs to be considered about training. Excuse me. You need to ensure that you've got the staff of the correct grade and skill mix. Do you need all sonographers? Should it be a mix of radiologists, registrars, as I've already mentioned? That will be down and dependent on your service. But I cannot emphasize enough, spend to save, invest in training time, because the quicker you can be confident in this technique, the sooner that this service will be valuable and a useful test. So we've got another case of a suspected pyelonephritis. So let's get the correct support. Should ultrasound be used? Is this an underlying lesion? And can contrast avoid further cross-sectional imaging? So this is a second case of a patient with this very complex looking kidney with these hypoechoic areas. On fundamental ultrasound imaging, again, there is a complex area there. It's hyperechoic compared to the rest of the kidney. So this is actually quite a useful case to use contrast to see what that perfusion looks like. And again, as you've seen earlier, at this kidney, you can see the perfusion all the way through the cortex. It's isoechoic, perfuses similarly all the way through, and that strange area of concern is actually an area of altered echogenicity commonly seen with pyelonephritis. This patient does not need a repeat CT. We've answered the question. There's no focal solid lesion within the kidney. It's a sequelae of the condition they are presented with. So it's not just about funding, but we need to support the service. So you may well have got your patients, you've identified which ones you're going to scan, you've got your contrast, you've got the machine, we've got the cannulation all set up, and we've got the team ready. But this is where we need to support what you are doing. Paul's already talked about the FSM guidance and NICE. I'm not going to go into it too much. But these documents really, really are helpful, and they should be your Bible for moving forwards with these tests. This was published in 2012. We're nearly 10 years on from this, and still we're not using contrast under this guidance that was published. If you don't know it, read it. It really will help you provide evidence as to why you should be doing contrast. The FSM guidelines, obviously with the liver, they were updated in 2020. They are really helpful, indicating when you should use it and what things should look like. But this document really, for me, revolutionised what we could do, in the fact that it backed up our non-hepatic use for contrast. And again, if you've not accessed them previously, then please do find them on the internet. And why is that helpful? So we scan, as I've said, a whole range of patients. This patient presents with a scan of his testes. He does have very atrophied testes, but he was getting pain in the right side. And we can see a small atrophied testes, but this area does look quite unusual, even in the background of an unusual testicle. Now, the FSM guidance for non-hepatic use tells you that contrast can be used and what to look for. So we've been, again, asked for opinion by Dr. X. He's identified this low attenuation imaging and has advised contrast, really to determine, is there an increased vascularity? Because if there is, then we need some urological referral. If there's no perfusion, or that it's the same as the rest of the testes, we can be reassured. So we do a contrast scan. This is at 40 seconds. You can see this arterial enhancement of this small area within the testes. And as we go through the contrast cycle, it remains hyperperfused compared to the background, but you can see perfusion through the rest of the testicle. So it is an unusual and suspicious finding. This patient needs referral to urology, and in actual fact, it was a small malignancy sat within an atrophied testes. And contrast helped us determine that and make sure he ended up on the right pathway. So you've got all of these things in place: patients, contrast, machine, cannulation. You've got the team. Really work out how and when are you going to support these lists. As I've mentioned, here in Hull, we have individual contrast lists once a week. You need to work it out for your service, how best to book it. How can you identify space, particularly under these pressured times of increased demand and post-COVID recovery. Supporting documentation, I won't talk too much about it. It's been covered really clearly by Paul earlier on, but just be aware of the difference between licensed and off-licensed use. Contrast ultrasound is absolutely fabulous in renal cases, testes, spleens, and they're the off-licensed uses. Think about whether you want to be using it in pediatrics. There's a really excellent book that's been published this year giving guidance on the use of contrast in pediatrics. You need to think about clear written policies, and do you think about having what sort of patient consent do you need, particularly for off-license use? Is verbal consent sufficient? Do you need a patient information leaflet that explains that yes, you're using contrast, these are the safety elements, but it's not licensed for what you're giving? So these are considerations you really need to think about. For non-prescribers, so that's non-medics, diagnostic radiographers still fall under this bracket of non-prescribers who are unable to prescribe. So you must work under either a patient group directive, which gives you a directive for the groups of patients that you can administer a specific drug, or a patient specific directive, which is effectively a prescription. So you need to think about that. We work with a patient group direction, and that tells us what kind of patients we can inject Sonoview. Now, our trust has actually agreed to that off-license use being written into this, which is exceptional, but we've done that because we've proven our work over 17 years has been safe. You need to make sure that you work within this multidisciplinary team, radiologists, pharmacists, to make sure that this process is written well and written into your scheme of work. And then you need to think about flowcharts. Paul showed you one what to do about an incidental finding. This is one from Hull. I'm not expecting you to read it in any great detail, but we have devised a flowchart for managing incidental findings, and that's at any imaging. So if they've found an incidental lesion, CT, PET, ultrasound, or MR, then first things first, make sure your previous imaging is reviewed. You'd be surprised how many times that doesn't happen. If it's a new finding, then we come down. If it's liver, if it's unknown, no known underlying significant pathology, then we advise contrast. If there's no malignancy, then that should go over to CT or MR, and also discuss with radiologists. And as you can see, we track down dependent on where the lesion is and what we need to do about it. But I have to absolutely emphasize, if you are not used to looking at cross-sectional imaging, you need to find a buddy who does. So always seek radiologist advice if you're not used to looking at different imaging modalities. And then wherever possible, we really should be looking at getting a second opinion from people who are experienced in the contrast scan that you're doing. And then finally, let's taste it. What does this service look like? So the aim of any audit is to evaluate your contrast findings and compare with any subsequent secondary imaging. Because how do you know you're right? There will be a period of time when patients are subjected to two lots of modalities. Just because you need to grow your confidence, your referrers need to grow your confidence. So effectively what we're asking, are our bubbles safe and effective as an imaging test? In your practice, can you make them work? So I'm just going to run through a most recent audit of Hull just in the last couple of minutes of this presentation. We looked at 205 cases. 140 of them just had contrast, 34 had contrast and fusion, but 31 who were listed for contrast, only we answered the question just using fusion guided imaging alone. And you can see the mix of organs. By far, renal imaging now is one of our biggest referral types. You can see the mix. Overwhelmingly, we look at benign lesions, as Paul mentioned. The vast majority of cases that you will see will be benign, so that hopefully is reassuring. Interestingly, we've got quite a higher percentage of malignant renal lesions there, and there will always be those indeterminate lesions. You either can't see them or you're not sure what they are. When we looked at our accuracy or agreement rate, not accuracy rate, we're not histology, but when we looked at whether we agreed with the CT or MR, then in the 30 cases of malignancy where CT suggested it was malignant, then contrast plus or minus fusion agreed with that. And similarly, when CT MR said it was benign, overwhelmingly ultrasound also said it was benign. There was just one case where we thought a benign lesion was malignant, and 5 cases where we thought that there were benign findings where in actual fact they turned out to be malignant. So if we look at those results, I think we've got high specificity and good sensitivity for characterization of our focal lesions. And when we actually look at the discordance rate, the discrepancy between contrast ultrasound and cross-sectional imaging, in actual fact, we disagreed in about 2.9% of cases. Seems quite a lot, but when you look at the published rates for radiological error, that's disagreement rates. The published rate is about 3 to 5%. And within non-contrast ultrasound, our discrepancy rate, where we've got disagreements, is about 3.4%. So we're happy that contrast is equivalent to known established services. So there are well-documented pitfalls to contrast, and until you start scanning it and building up your confidence, those pitfalls could remain a barrier. There are perfusion characteristics of different lesions which can be quite difficult and can be artifactual. Just be aware of that. But it is really important to be aware as well that misinterpretation can add to some of those pitfalls. So you must learn, you must access training and just embrace that shared learning. Who's going to be in your team? What are you going to image? Are you going to limit to a single organ? Are you going to audit your activity? These are all considerations for you performing contrast in the multi-professional team. And I hope I've given you a really good overview and summary of where contrast can really benefit your service and your patients. I'll leave you with a short case here of an indeterminate lesion on CT, which we can see here with fundamental imaging. And when we add contrast to it, you can see this really arterial flow, excuse me, in a small central scar. This patient's question has been answered by contrast enhanced imaging. So I just want to say I'm aware that we're just running out of time. So I just want to say thank you for your attention and happy to take any questions. Thank you very much.
Thank you, Pam, and thank you, Eddie, for both of you for doing a very good job on the lectures. Really enjoyed both of them. Now, there's a couple of questions online which I'll come to, but I just 1 or 2 points to make. It never ceases to amaze me that when NICE issues guidelines on doing a CT head, if you bump your head on the door, that we have 100 CTs in a weekend to look at. But NICE recommends 10 years ago that you should look at every indeterminate liver lesion with contrast, and maybe 1 a week is done. So it's a bit strange to me, but I also appreciate that we're time starved in the health service in the United Kingdom. And congratulations to you, Pam, for setting up this service with collaboration. And do your clinicians buy into it?
Yes, definitely. In the early stages, it was a little bit difficult, but that's where the collaboration really worked. Having radiologists, the MDTs was slightly different work 17 years ago, but being able to present those findings together, as opposed to a sonographer or a radiologist as lone isolation. We were proving it worked. So yeah, nowadays we get referrals from MDT for contrast.
Yeah. And it works the other way. It's the indeterminate lesion in the MR and CT. And the question that you were asked online was, when you were first setting up a CEUS service and learning, did you follow up your CEUS results with, say, MRI to back up your diagnosis with contrast?
Yeah, so I think it was about the first 8 months, every case that we did had cross-sectional imaging at the same time. They had double imaging for certain. It's possibly easier now. There was less published back in 2004, but yeah, we did within the service do that, and that's the financial hit that I think we have to take.
Yeah,
I
think, and with Eddie as well, we're talking 15 to 20 years ago when there wasn't evidence out there that we always did have backup in the early days, but now the characteristics of lesions are so well documented. It's really straightforward. Eddie, a question for you. Do you do all your procedures under ultrasound guidance, or do you have to resort to CT or fusion imaging?
So the first one is I have the luxury of having both CT and ultrasound. Okay? But there was a time when, my early experience was purely under ultrasound guidance for the liver. Beyond the liver is a bit more difficult, but certainly, with ultrasound, if you are doing purely with ultrasound, it is essential that you have contrast. Otherwise, you're going to fail. Simple. Yeah. With regards to fusion, while I do agree with Pam, its usefulness, the problem about fusion imaging is the setup. It takes a long time to actually get the setup right. And if you've got a busy practice in terms of intervention, it's not really practical to work. I think it's a great teaching tool for the geo doctors to use fusion imaging to learn how to guide needles. But in real practice, if the companies could really facilitate the workflow in setting up fusion imaging, that would be great. And one of the limitations I would say with fusion imaging for intervention is the fact that, just bear in mind, when you put the needle in, there is a distortion of the tissue. So you can get misregistration very easily. So one has to be very careful about insertion, and that's where planning in advance would be very useful. But all this takes time, and if you've got a busy practice, it can be more of a hindrance, I would say.
Yes, I think Pam, you wanted to comment there.
Yeah, I can see Eddie's point, particularly from an interventionist, and also this is a benefit of being a radiologist. You've got that CT cognitive knowledge in your head. For us as sonographers, I think fusion actually helps the confidence if you're following up, because a lot of our work now is incidental findings from cross section. I actually found it sped up my service, because I can fuse. I know that's the lesion I'm looking at. That's it. I'm not faffing about looking and searching. So I can see pros and cons. We do prostate biopsy under fusion. We don't do a lot of other biopsy or interventional work under fusion.
Yeah, but I think there's a difference in intervention and diagnostic,
absolutely.
Yeah, definitely. But also the point you brought up earlier, Pam, about this is a focused problem-solving tool. And I think this is absolutely the truth about contrast enhanced ultrasound. You are focusing and you're making a diagnosis. And this is where the radiology community will fall down in the long term, particularly when other practitioners use ultrasound. And you see this in Europe, where gastroenterologists and the renal physicians don't have ready access like Eddie does to a CT scan, or you do to your fusion imaging. Maybe they will have fusion imaging, but they use it as a problem-solving tool. And this is where it'll go forward. It doesn't mean radiology can't do it, but it's got to be recognized as that. Okay, I'm just going to look in the chat to see if there's anything else in the chat there. I think I've answered the chat questions. I think unless there's anything else that we need to discuss, it's almost 8 o'clock, and I think I can hear some rumbling tummies out there. So if there's anything else Eddie or Pam wants to bring up, I'll just summarize and say, well, you've got all the evidence for contrast. It's been around there now for 25 years. The Americans have finally recognized that it's useful. even in the time-starved National Health Service, it's useful for your patients. And I think that's the most important thing. It's patient-friendly, it's safe, and it gives that patient who's interacting with the observer the answer straight away. And I think that's the key to it. And radiation, we will be told eventually that we've got to stop irradiating people so much. And this pressure will not come from our fellow doctors or paramedical staff. It'll come from the patients. So thank you very much for listening in this evening. I hope you all enjoyed it, and I hope you take away some information. And as I've said earlier on, it's all available online. Thank you for listening, and thank you to Pam and Eddie for excellent talks. Good night, everyone.